Hi, I'm Dr. Dror Paley, the director of the Paley Orthopedic and Spine Institute in West Palm Beach, Florida. Thank you for joining us today, and I'd like to first remind you that if you have any questions during the presentation, feel free to go to the Facebook page and submit them electronically, and at the end of the presentation I will do my best to try and answer all the questions. Okay, well, let's get going. I did a presentation a few weeks ago on the latest and greatest, which was the precise plate, and got a lot of requests to give a historical perspective of where we came from, what's the history of limb lengthening, and then how we got to the present, and what's the future going forward. So I've been very involved in this field since, 1985, and really was one of the first surgeons, if not the first surgeon, to start doing the newer techniques of limb lengthening. Limb lengthening's been around, as you're going to see, for more than 100 years, about 120 years. But the newer techniques of limb lengthening really are attributable to a guy named Professor Ilizarov, who I went and visited and brought his techniques over to North America. And that's kind of where my journey begins. But before we get to that, and before we get to talking about his device, let's look at the entire picture. And the entire picture is that limb lengthening started off with devices called external fixators. And these are devices that bolt on the outside to the leg. And let me show you the history of these devices. Before that, you can see from our screen, those of you who've been here know this. I mean, the Paley Institute is in that building there, and it's on the campus of St. Mary's Medical Center. It's a beautiful campus, 100 acres of beautiful vegetation, lots of palm trees, and of course, beautiful Florida. So let's start this presentation. So the earliest devices were called monolateral external fixators. These were devices that bolted to the side of a bone. They weren't rings, they were just kind of a bar connected to pins. And actually, as Americans, we can take pride in the fact that the very first external fixator actually came from the United States in 1895, a guy named Dr. Clayton Parkhill in Denver, Colorado. And of course, the biggest problem plaguing bone and joint surgeons was fractures, broken bones. And so the first external fixators were used in order to fix broken bones. And this at a time when nothing else was used to fix bones except for a cast. And so you can see a little bar and 4 pins attached to the bone. But 125 years ago, it's amazing to think about that. And in Europe, this also took hold. Alvin Lombat, sorry, that moved, but in 1902, did that in Belgium. And then in Italy was the first use of external fixators to lengthen legs. And the first guy to do this and published on it is a guy named Codavilla from Bologna, Italy. And what he did, he kind of used more of a traction device. But the first guy to really use an external fixator was his student, and his name was Vittorio Putti. And Putti had this kind of 2-pin device with threads that you'd move, and you kind of did a Z-shaped cut of the bone and then slowly pulled it apart. I want you to look at the year. Okay, 1921, he was publishing on this. Okay, so long before any of us were around. And he wrote this: elongation, meaning lengthening, can be effected only by osteotomy, that means cutting the bone, which however must be performed in such a way to facilitate the formation of the callus. Callus is the new bone growth. So they knew back 100 years ago, 1921, literally 100 years ago, they knew that you could break a bone and pull it apart and it would grow new bone. So anybody who thinks this stuff is new, okay, this stuff's not new. It's more than 100 years old. Really amazing. Limb lengthening continued on. Lots of people continued to do limb lengthening. In the United States, there were numerous people all over the country who published on limb lengthening. But we're talking about monolateral external fixators. So the next big advance in monolateral external fixators was a guy named Heinz Wagner from Germany. And Heinz wanted to make this faster. And in order to make it faster, what he did is he not only developed a better external fixator, his was the first portable device. You didn't have to lie in bed. You could have this external fixator. You could turn it with a nice little knob. Kind of looks like today's devices. And faster than the usual rate, which caused all kinds of problems, nerve problems, muscle problems, so on. And because he was going too fast, bone wouldn't form, so you'd have to put a metal plate and add bone graft to it. He set us back 20 years, maybe 30 years. All the knowledge that was known until the 1960s went out the window. All the knowledge until then was bone and muscle formation, and there's 50 years worth of publications on that. And this guy, in trying to speed this whole thing up, set the whole thing back, and everybody forgot everything that was done for 100 years, for 50 years. The next big advance in these monolateral devices was in 1982, again out of Italy, a guy named De Bastiani out of Verona, and he developed the Orthofix device, which is one of the modern devices of limb lengthening. In fact, when I went over to study, so I trained in Toronto, finished my medical school there, finished my orthopedic residency there, and then I went off to do some subspecialty training. And so I went to Europe to do that. And I studied with Ilizarov and I studied with De Bastiani. Okay? These were the two big gurus. And he had developed this monolateral device. But what he was doing is he now went back to the ways of bone regeneration, which honestly the Italians had discovered, as I mentioned, way earlier, 60 years before this. And he applied that. At the same time, bone regeneration was really being credited to a guy named Ilizarov, and the Italians were the first to visit Ilizarov. So Italy knew about these modern methods, but they also knew about these old methods from way back. And so this was kind of the newest device, and this is still being used today, this De Bastiani or Orthofix device. The next big advance came, it was actually my invention. We called it the modular rail system in 2009. And in fact, the very first operation I did at St. Mary's Medical Center at the Paley Institute here in Florida was the first one of these. I developed this in the previous years, and then I applied it to the first patient. It was the very first surgery done in this hospital by me, and it was this device. We put this device on. The beauty of this device is that it could go across joints. So you could have a hinge at the knee, so allow the knee to move, hinge across the hip, allow the hip to move, and it would protect the joints from pressure. It would protect the joints from dislocating, which especially in kids with like congenital femoral deficiency who are born with unstable joints, we could stabilize the joint while lengthening the bone. So this was a big advance. And then, this is just an example of one such kid. You can see how he can bend his knee while he's lengthening. They're turning this screw-like device on the side in order to lengthen. The next device was also mine. I couldn't get the company who made the modular rail system to modify it and advance it. So I decided to develop another one and created another company called Devise Orthopedics. And together with a new group of engineers, we designed what probably is the most advanced monolateral external fixator that exists today. And this is what we currently use. And I designed this specifically for doing this on patients born with congenital femoral deficiency. So many of you who have children with congenital femoral deficiency are familiar with this. But we've used this also on patients with dwarfism, with achondroplasia, and with many other conditions. It's fantastic for arm lengthening, lower limb lengthening, and so on. It is the most modular device that exists. It lengthens by turning a screw on the side, so it's actually lighter weight, doesn't have all these outriggers on it, and it has the most versatile ability to put in pins. And it can also allow the hip and the knee to move while lengthening. So it really is like I said, it's the most advanced monolateral external fixator. And one of the things I'm going to show you in this presentation, listen, I was in the right place at the right time in the 1980s. I heard about Lazarev. I went and started studying this stuff before anyone else did. And I started practicing. I was the first person to dedicate my practice to limb lengthening and deformity correction. And as part of that, what has happened, and you're going to see this, is I've gotten involved at all levels of this science in developing these newest devices in order to improve the care for our patients, so that our patients can have the most cutting edge, best devices. And with my access to a lot of orthopedic companies who have cooperated to help along this journey and to create these newer devices, we now have developed the latest and the best implants for all aspects of limb lengthening. So part of this is that you're going to see that monolateral external fixators, circular external fixators, and implantable lengthening devices all started before me. But the latest and the best ones that exist out there are all ones that were developed with my input, many of them at the Paley Institute and in collaboration with many companies out there. So this is just one of them, and you see how it lengthens and allows the joints to move. We wanted to be able to correct deformities at the same time as lengthening. And so we developed special swivel clamps, which not only allowed us to lengthen, it allows to shift bones around, lengthen, and angulate while allowing the joints to move. So again, this is this new device called the drive rail. It's not that new, it's been around now for a good number of years. Circular external fixation. So monolaterals came first, and that's why I took you through the evolution of monolateral external fixators. But what came after that were circular external fixators. And the most famous one of all is the Lazarev device. And we'll talk about that as well. And there are newer ones, as we're going to talk about. But let's see, how did these come into the picture? How far back do they go? So the earliest one that I could find was essentially almost like what we call onboard traction. So if you had a broken bone, you could kind of put a pin at each end, a single pin, attach it to a ring, and these outside struts, and that would stabilize the broken bone. And the whole idea is you could let a patient move around because you had these rings around the leg, and it would hold it together. 1913 in the United Kingdom. Then you can see it went from circular to semicircular. 1930, Clapp and Block created this type of device. Again, most of these were for fracture fixation. They really weren't done for lengthening. But as I mentioned, a lot of Americans were involved, and these are some of the American devices. And these were bed-mounted devices. So can you imagine, in order to get your leg lengthened, you'd come into the hospital, you'd never get out of bed for months. They'd put you in this device, your leg would lie in this cradle with pins going through, a cast on the leg as well to stabilize it. You see all the pins going across. And the nurse would come around. At the bottom there's a crank, and the nurse would come around each day and go, whoop! The patient would scream, and she'd walk away. Okay? That was limb lengthening in 1932. Okay? So limb lengthening come a long way. Here is 1939, the beginning of World War II. Okay, semicircular device. Okay, by Abbott and Saunders out of San Francisco. So these things existed long before Lazarev, long before any of the current guys. The first circular device with tensioned wires like this, that was like the Lazarev device, was actually conceived by a guy named Whit Moser in 1953, but was never used. It was published, never used. And it looks identical to the Soviet device, which Professor Gavril Abramovich Lazarev, who is considered the father of modern limb lengthening, developed. Now, looks like some of the other devices, but what is special about Professor Lazarev? We saw 1903, we got Cottavilla in Italy, all the way to 1950, so almost 50 years before Lazarov brings his device. And he, by the way, he lives in some remote Soviet village in Siberia, not even in a major city like Moscow or St. Petersburg. He lives somewhere in Siberia, so no one even gets to hear about his device for a long time. But he starts treating a lot of course, veterans out of World War II. In 1951, you can imagine, fixing a lot of the bones that had been blown up and smashed and so on from World War II. But also, you know, motor vehicle accidents and all these things that existed everywhere. And he initially used his device for broken bones. Like everybody who invented an external fixator, they were first applied for broken bones. But then he realized that if he turned the knobs on it, he could lengthen the bone. Now, was he exposed to some of the old literature from the previous 50 years, or did he come up with this himself? It's hard to know. It's very hard to know. I went and met him for the first time in 1986. Okay, so it's during the Cold War. I was a Canadian, and so for me, it wasn't that hard to get a visa to the Soviet Union. And I went over there. I taught myself Russian, and I studied with him. I was there in 1986, 87, and 88, cumulative time of about 3 months. And then I also spent about 4 or 5 months in Italy, which was the first country in Europe to adopt his methods. Okay, so I spent a lot of time trying to learn the Lazarov method. Not an easy method to learn. Now, here is a picture from 1987, 32 years ago, when I was at the University of Maryland, and I was an assistant professor back then, eventually became full professor at University of Maryland, and this is with Professor Lazarov, his first trip in 1987, okay, to the United States. I'm showing him some x-rays with his device because I was already using his device since 1987. Okay, I started using his device before I left Canada. I did my first 52 cases there and then moved to the U.S. And when I moved to the U.S., patients started coming for this treatment to me because I was the only person doing it from all over the United States and in fact all over the world. And that's how kind of my practice began. And for a 32-year-old young surgeon, this was, wow, what do I do with all this? And it's been an incredible learning curve. 25,000 surgeries later, I'm here telling you this story. So the Lazarov device dominated limb lengthening for the next 10 years. But so from 87 to about 97. But in 97, the next generation external fixator came up. The guy who developed it is a guy named Charlie Taylor out of Memphis. And it is referred to as a 6-axis computer-dependent external fixator. It basically means it's a computer-assisted device. And for the first time, you now had a device. The Lazarov device, think of it as an analog device. And this was a, let's call it this is a digital device that came out. And now, the American guy who patented this in 1996 turns out wasn't the first one to think of it. The French had thought of this in 1985, and there was a patent already published on this. But nothing happened with it. The Russians had even talked about this in '89, and nothing happened with it. And a German in 1996 did stuff with it. Nothing much happened with that. It wasn't until this guy, okay, Charlie Taylor, guy from Memphis, came out with this new device, the Taylor Spatial Framework called TSF, that everything changed. And around the beginning of, and there were others, by the way, that came up with devices. And around the beginning of 2000, all of us were using these computer external fixators. They had 6 struts, and that was the critical thing. And they allowed you to plan things, and then it would move any way in space that you planned it. It was so much easier to use than the Lazarov device. So it's like going from analog to digital, okay? And it wasn't intuitive, unfortunately. You know, the Lazarov was very mechanical. You could always figure it out. This thing, you needed a computer. You needed to kind of enter parameters. It really lent itself to when digital x-rays came out. And it is the standard today in circular external fixators. Now, when the patent lapsed in the early in around 2012, a lot of new devices came out, and at that point I developed a new device called Orthex, and this is the most advanced and friendliest software that exists. It involves intuitive planning using a special way that I published in 2001, and it was launched in 2016. And if you come to the Paley Institute, this is the device, if we use a circuit or fixer, that is applied to your leg. It allows the correction of the most extreme deformities, okay, and the most complex deformities, more than any other device that exists. It's the first device that can correct deformities greater than 90 degrees in multiple levels and so on. It's got a pediatric version, which is about 60% lighter, and it has these rings and these struts and so on. Okay, and you can see you can put rings at 90 degrees to each other, and the computer software analyzes how to fix the deformity, and it tells the patient, gives them a schedule of how much to turn each of these rods. We added these things called Z-plates, which extend beyond the ring and which allow you to get the rings literally very close together, which other devices could not do. This is just an example of a patient with a very, very severe deformity with a condition called tibial hemimelia, and because of these Z-plates, we could do this. With the older devices like TSF and others, it was much more difficult to manage a case like this. So this changed everything. And currently, you know, this is the standard of care, is the Orthex device. It's the most advanced and also the most friendly for kids because it also has a very lighter weight, module. So there's two versions. The bigger rings and bigger struts and the smaller ones and the smaller struts much later. So this is when the leg is completely straight, and you can see this is used sometimes together with the monolateral and the circular together. So these two devices, because I designed them to basically connect together, and there's a hinge, and you can bend your knee. Patient can walk on one of these rings, and they can lengthen femur, tibia simultaneously. So this is kind of, and we still use these techniques today. Notwithstanding some of the newer developments, this is not going to go away. This is going to be around for a good while. Talked about the software. So what the surgeon does, they go in and they have to point, it's a tibia or a femur, right or left. They have to say what type of they used a partial ring, like that goes part of the way around, all the way around. What size it is. So it's all entered on the computer, the size of the struts and so on. And then digital x-rays are uploaded, and the surgeon draws the axes of different things. And what that does is it gives the computer the information, and on another page, using that information, which is auto-populated, you kind of tell the computer how fast you want to lengthen, let's say a millimeter a day, and how many of these deformities you want to correct, if you want to do it all at once or in multiple steps. And then the computer gives you basically a virtual animation of what your deformity correction is going to look like in the different directions. And you can see this is showing how it's moving in the front view, the side view, and also even if you like a bird's eye view, how it's rotating the leg around. So this is what we do behind the scenes in planning some of these very complex deformities. From the patient perspective, you get a schedule, and the schedule prints out what the numbers on each strut. Every color is a different strut. And to make it friendly, could also report how many clicks in the morning, midday, and evening, and so the patient knows when to turn strut 1, 2, 3, 4, 5, and 6. And what's coming probably is a motorized version where you plan all this on an iPhone. The patient never has to touch anything. Right now it's manual, and it's still done that way. External fixators rely on pins. So we always talk about the fixators, we forget to talk about the most bothersome thing of all, which is the pins. And the pin technology has advanced a lot. And one of the problems with pins, they go in the bone, they go through the skin, the muscle, they anchor into the bone, and they loosen, and then they get infected. So we had to, if you can't get a good anchor on the bone, and if it loosens from the bone, then your fixator is then loose and painful and so on. So a company called Orthofix came out with covering the end of the pin, the threaded part, with what's called hydroxyapatite, which is the mineral that's inside of bone. So it fools the body into thinking the pin is made of bone. So it attaches to the pin instead of moving away from it. If it's just pure metal, it often moves away from it. So HA coating. And the other, I helped a company called Smith & Nephew design their pins, HA coated. And then the latest and the greatest are these. And this goes with the Orthex system, which is that system I just showed you, which is the ring device that we use. And these pins have a lot of really cool features, but not only is the HA coating on the threads of the pin, but it comes out the skin. Turns out that the soft tissues like it too. So they grow into it. Instead of a shiny metal surface that the soft tissues can't attach to like the skin, which leads to infections. If you have a rough surface like the HA coating, just like soft tissues attach to bone, okay, they attach to the HA coating. And so we were the first to bring that out, and it reduces the pin infections and the pain and the loosening tremendously. And we not only coated the big screw-like pins, we also coated the wires. So these pins are now available, and they reduce the pain for our patients. They reduce the complications, reduce the infections, the loosening, and all the problems that have plagued external fixator since 1895 when they were first invented. Okay, let's move away from the external fixation. So external fixation is the way this was all done for, well, I guess for limb lengthening since 1903, okay, until you're going to see 1983. And after that, people started thinking, could we lengthen with devices on the inside of the body? And so let's look at a little history. The year I was born, 1956, a guy from San Francisco published a paper, Experiences with Limb Lengthening of the Femur over an Intramedullary Rod. An intramedullary rod, intramedullary means the inside hollow part of the bone where the marrow cavity is. So he placed a thing called a rush rod inside the bone, okay, and he lengthened over top of it to align it. Not very stable. They were using very primitive external fixators. In 1997, I published a paper with almost the same title, Femoral Lengthening over an Intramedullary Nail. The difference is we put in the type of nails that we now use when you break your femur or tibia. These are basically little pipes that go inside the bone, and you put screws across them. The advantage was if you put one of these rods in, lengthened with an external fixator, you could then put screws across this and take the fixator off early. So it reduced the time the external fixator was on by 2/3 to sometimes 4/5. So you greatly reduce the external fixation time. And patients hate external fixators ultimately. So it reduced that time to wear the external fixator. So this was called LON, or lengthening over nail. Okay, so I started in 1990 and published in 97. And then we added to that, if you wanted to correct the deformity, you could also break a bone, straighten it, and rod it. And this was called FAN, fixator assisted nailing. Both these techniques are still used to this day. These are both techniques I developed and published a long time ago. But what about fully implantable devices? Lengthening not just where you put a rod in and put an external fixator on, but a device that self-lengthens. So the guy who deserves credit for this, the very first guy, is this, interestingly, another guy from the Soviet Union, a guy named Alexander Bliskunov. I met him. He actually became a very good friend of mine. Stayed at my house in Baltimore when I used to live there. And he was the first in 1983 to develop a fully implantable device. So this was a rod that goes in the bone, and then it came out of the bone and bolted to the pelvis, and it was like a crankshaft. So you would turn your leg side to side, as you see this guy doing, and that would ratchet out the device, and it would lengthen the leg. Pretty brilliant, 1983. Now 1983 is before I got involved in all this. I got involved in 1985. World had never heard of this guy either. And so he was in Simferopol, Ukraine. Okay, and imagine on the one side you've got a Lazarov in the Soviet Union doing these incredible things with external fixators, and on the other hand you have this guy who's now doing futuristic type of lengthening, at the time considered heresy, with an internal device. He was way ahead of his time in 1983. The first commercial device in the West was this thing called the Albizia nail. It came out of France. As a medical student who came up with it, Jean-Marc Guichet, a friend of mine. And this thing, similarly, the bone was broken, and he created like a ratchet on the inside that if you shook your leg a certain way, it would lengthen. Problem is, it was hard to control the rate. And another American in 1994, Dean Cole out of Orlando, developed a similar device. It required even less effort to lengthen. The problem is the nails would run away. So, you know, the rate of lengthening is really important. Never going too fast, otherwise you get nerve problems, muscle problems, joint problems, and so on, and even circulation problems. So this was the first FDA-approved device. 2001 came out. I personally put 450 of these into patients, okay? And yeah, we learned all kinds of ways to control the rate with external braces and other things. It wasn't the ideal device, but it heralded in the United States the beginning of implantable and lengthening. Now, we also used the Albizia nail. It was never FDA approved. We were allowed to put 10 of them in. I put about 10 of them in the 1990s. Terrible device, really big problems with it. Lots of problems with this device. But at least it was FDA approved, marketed, and we worked through this. And our learning curve in the first decade of 2000, from 2001 to 2011, taught us what we need to know today to advance the science. So this was a very important step. Even though the mechanism wasn't great, the big step is that it got FDA approved. It opened the floodgates for other devices to get FDA approved. So the next device was a company called Ellipse and a colleague of mine, Stuart Green, who developed what was called the Precise nail. And I had the privilege of putting in the first Precise nail on December 1st, 2011. And so this device was magnetically controlled. We had an external magnet from the outside, and it would spin around. It would grab the magnetic field of a little device inside the rod, and it would cause it to telescope. It could go forward and backwards. First device, implantable device, that can go both directions. So this was like a next generation device after the ISKD. And I got involved with this device after I started putting in what we call the P1s. I didn't develop the P1s. That was developed, as I said, by Stuart Green and a company called Ellipse. Problem is the P1s broke. They worked, but many of them broke. And they had mechanism breakages. They had the nail break. I was asked to help redesign the device. And we developed the P2. And the P2 was a lot better. It had very few of the problems of the P1s. And I want to put it in perspective, the P1s still did a great job. They were better than the ISKD. But they had problems, and we don't, we're very intolerant in the United States of having a problem. And so we needed to improve it, and we improved it quickly. The company was very responsive, and they changed all the things that were problematic, and we developed the P2. And there are a couple other modifications. So what's available now is the P2.2, which I helped design, and that really is a fantastic product. It's made out of titanium. It lengthens really well. It's very controllable. It's very reliable. It doesn't break. We used it for all kinds of things, like increasing people's height or treating leg length difference. And here's just an example. One of the things that has now become much more in demand is stature lengthening, not just for patients with dwarfism and low stature, but patients with normal stature who desire height increase. So that is one of the things that's done with these internal devices. You can see lengthening with these internal devices. This was lengthening of more than 4 inches, 10.7 centimeters, of both bones, femurs and tibias. Going back in time a little bit, you know, one of the things we did with these implants was lengthen patients with dwarfism. We started with external fixators. And our protocol, which is different than everyone else's, even different than Lazarov's, was to lengthen both tibias, both femurs at the same time, and to do it 2 or 3 times during the lifetime, 1 time to do the arms. So you can see here's a patient, here's the monolateral fixator, that's the orthofix device. Remember that original Italian device? I was using that in the 80s and 90s, and you can see the lengthening of 4 segments at the same time, and the girl did great after this, gaining 4 inches, okay, at age, I think 7 here. And then doing this again around age 12, gaining 6 inches, again with these orthofix devices, okay, and being able to reach the ground, and then doing, you know, she eventually has plastic surgery to the scars, and here she is next to her friends. I mean, normal height compared to all her peers. And so one of the things we've been able to do very successfully has been to lengthen patients with achondroplasia and hypochondroplasia and get them to normal heights. Okay, these are lengthenings that cumulatively are 30 to 40 centimeters. That's 12 to 60 inches total. Okay, nobody had ever done that. Huge amount. Why am I bringing this up out of order here? The reason is because this is a very arduous process. And it's not easy to have an external fixator on once. Imagine having it on for 3 lower limb lengthenings and 1 upper limb lengthening. Okay, and it's kind of, you know, an end to a mean, but it's a little bit of torture. And I know that I've put my kids through these growing experiences, but not easy growing experiences. Well, this is what we do now. No external fixators. Fully implantable lengthening for patients with dwarfism. Okay? We're done. It's the last time we're doing lower limb lengthening in dwarfs with external devices. They will all be done with implantable devices now. We'll talk in a bit about the next implantable device. I mentioned the precise plate, but either with these nails that go in or with the plates, but no more external fixators. So when we're looking at this in a perspective, look how things are different. And now when you have to put someone through 2 or 3 lengthenings, it's not such an arduous process to just change a rod and have very few scars on your limbs and go through this process. So this is what we are currently doing, and it just shows you the evolution as now you've seen kind of a little bit of the history. The latest and greatest in that is the stride nail. This was also something that I invented, and the stride nail is, by the way, it's manufactured by a company called Nuvasive. Nuvasive Specialized Orthopedics is the full name. And they bought Ellipse and acquired this technology several years ago. This device, what's new about it, it's the first device that allows full weight bearing. So the previous device I mentioned was titanium. Titanium is flexible, and it's not strong enough to allow people to walk full weight on it during the lengthening. This device is. So this device was redesigned, different metal, it's a very durable, hard stainless steel called BioDur, and different, you know, changed the mechanism, changed a lot of things, so that the 10 millimeter diameter rod can bear up to 150 pounds, so we'll use that in people under 150 pounds. The 11.5 one can allow someone up to 200 pounds to walk without crutches, and the 13 millimeter diameter one up to 250 pounds without crutches. So during the entire lengthening process now, whether it's one leg or both legs, whether it's 2 segments or 4 segments, we can allow a patient to fully weight bear. They could be walking by and you have no idea anymore that they are undergoing lengthening and that they have 1, 2, 3, or 4 lengthening devices in their legs. And it can also be used for arms as well. So this is much stronger than the precise, and it's just a strength comparison showing it's 2 to 3 times stronger than the precise. And it allows weight bearing, as we already discussed. How do these lengthen? We use one of these external remote control devices. The patient puts it on their thigh or leg, wherever it is. It spins around and it grabs the internal magnet and it causes this lengthening. You have a digital monitor that you read, which tells you exactly how much you've lengthened. An example, which I showed you stature lengthening with the Precise device. Well, this is a 4-segment stature lengthening with the stride nail, and after it's removed. And what it's showing you is this patient was walking around the whole time. No crutches, no wheelchair. Okay. Now, limitation of the stride is that the smallest Precise is 6 inches or 150 millimeters long. Okay. The smallest stride is 235 millimeters long, so it's much larger. And the smallest diameter Precise 8.5, smallest diameter stride is 10 millimeters. So there's a size limitation to being able to use the fully weight-bearing nail. Here's a patient with congenital femoral deficiency, and this patient's only 2 years old. So we did an operation called the super hip and fixed the hip and the ankle. And then it came time for lengthening. Now, only 3 years old. No device on the market small enough to go inside the bone. The Precise plate had not yet come out. So what we did is we bolted these nails, which are designed to go inside the bone, but the bone's not a big enough diameter. We bolted them to the outside of the bone. And so we began what's called extramedullary lengthening, which is now a published technique, and this precedes the use of the Precise plate. So I'm showing you an evolution that we're now headed from the inside of the bone to the outside of the bone, devices that are on the surface of the bone. So what started is actually using the same internal devices, but on the outside of the bone. And this lengthened and lengthened. You can see the lengthening gap. Okay, it just has one pin at each end. It needs a guide rod in the middle. And same thing in the tibia. Okay, so we can do it femur or tibia. And finally, the Precise plate. So this is kind of the latest and greatest, the newest technology of all. We presented it in September when we implanted the first Precise plate. I conceived of this device in 2012, went to the company that then was called Ellipse, and said, hey, we've got these lengthening nails, but we have lots of patients who would benefit from a lengthening plate. And there is no lengthening plate, and there never has been a lengthening plate. So what about doing that? Well, initially, what? Who wants a lengthening plate? Why would we need that? Well, the thing is, there's lots of patients where the inside of the bone is too narrow. And so we need something that fits on the surface of the bone. The other thing is, in the tibia, to put these devices in, you have to go through the growth plate. So you don't want to damage a growth plate in a young child. So going on the surface of the bone, you stay away from the growth plates. So a lengthening plate has a huge advantage. And the first lengthening plate was implanted by us on September 10th, 2020. And on that day, we put 2 in the tibia, on the tibia, 1 in the fibula, 1 in the femur, for fibular hemimelia, tibial hemimelia, and congenital femoral deficiency, all congenital problems. And this thing's 145 millimeters, just under 6 inches, so it gives you an idea of how big that is. That's the tibial plate. That's a femoral plate, which is 165 millimeters, a little bit bigger. And there's Dr. Shannon here with me, and this is on the day we implanted our first one. So this is what it looks like. It sits on the surface of the bone, and then it extends through here. It has the same mechanism, the same magnetic mechanism as the Precise and the Stride nails. Okay, it's the same company, Nuvasive. And it's all internal. Physis means growth plate, so it avoids going, that's a growth plate there, avoids putting a rod through the growth plate. And so it's a safer solution. Especially in the tibia, where you have a very important growth plate at the upper end. And so normally a rod would go through the top, near the knee, and go through, but it'd make a hole in the growth plate. This fits below the growth plate and above the other growth plate. So this is a very, very safe way to lengthen. It also allows us to correct deformities. So it's easier to correct a deformity with the plate than it is with the nail. And so if you have an angulation, you can correct that angulation and connect it to the plate. So this is a big, big advance. And we're only beginning to learn what we can do with it. Well, let's look at this case. This is a girl with fibular hemimelia. Back in 2016, I did the super ankle procedure. And then I put on an external fixator. I mean, the one you saw, the Orthex device, and I lengthened her leg. Okay? And I lengthened it 5 centimeters, 2 inches. You can see it there. And everything went fine. She did terrific. And then she grew a little bit crooked, which often happens. The kids' growth plates do have a mind of their own. And when she came in, she had a little bit of recurrent foot deformity. She has a little bit of knee deformity. So in the next surgery for lengthening, and she's ready. I mean, she's now, I think she was, this 3 years later. She came back for lengthening. And you can see she has about an 8 centimeter difference. So time to do another, 4 or 5 centimeters lengthening. So we want to straighten the knee. We want to straighten the foot. Okay? Can we do that with a plate? Well, so we put on the device, straightened the knee, held it with the precise plate, cut the bone at the ankle, straightened that, so the foot is perfectly 90 degrees now, and still held with the same plate. That's pretty cool. The fact we could only do that with an external fixator before. So with a circular external fixator, this is easy. But with a plate, you couldn't do this with a nail. With a plate, we can do almost the same things we could do with a fixator. I mean, that's really exciting. And here she is. She's still under treatment right now because remember, this was September 10th. She was the first patient treated this way. And she has lengthened, I think, about 3 centimeters so far. Look at the beautiful bone forming. In fact, bone forms better with the plate than with the nail because the nail goes in the middle of the bone. So it's taking up some of that space where you'd have that new bone. And so this is really exciting. She's had no problems. She's had no pain. Her dad's been interviewed. I'm comparing because they have the ability to compare the external fixator to the plate. And for them, it's like night and day. No pain. This girl is in and out of the hospital a day or two. She's had really no issues, no complications, and she's walking around. She's weight bearing with this on. So she's been doing physical therapy, coming for follow-up, and obviously we're not finished with the treatment because it's only really a month and a half since we started. Here's a boy with bilateral congenital femoral deficiency, and I treated him with doing super hip both sides. He has a leg length difference. The right is shorter than the left. We need to lengthen that. This femur is 9 centimeters long. Okay? The shortest plate, the tibial plate, is 145 millimeters. Shortest femoral plate is 165. So how do you manage to lengthen a femur that's only 9 centimeters long? So the cool thing is there's a lot of room in the soft tissues above the hip, kind of in the buttock area. We put on this device knowing that. And yeah, this portion where the screws are is only 9 centimeters long. The break in the bone is here. This is the hip joint, that's the pelvis. The excess sticks up in towards the buttock where they can't even feel it or see it. Okay, patient has no idea this device is longer than their femur, doesn't feel it. Hip moves, knee moves, and you're lengthening. Look at that new bone forming and it's lengthening. No external fixator. This is revolutionary. We've never been able to do this. This is incredible. And, you know, in the thigh, you got a lot more soft tissues. They get more infections, more issues, more pain. This kid has no pain. Therapy has been so easy because of lack of pins and everything else. And he's quite young. And he's got a really tiny femur. So this is the shortest bone that we've lengthened with the precise plate. Really exciting. So, look, I've gone on for a while here. I want to kind of bring it into some closure, and where are we going? So it's been, I probably have a different and better perspective than almost anybody in the field of limb lengthening. You know, some people were doing limb lengthening and they retired soon, sometime after the Lazarev method and all these newer techniques came out. So they're not really, they don't have the full perspective. Other people are just starting or started somewhere in the middle. I guess being the first one to do these newer techniques and to bring these techniques over, in 2020, I'm the only person who can say I have the full perspective of the modern techniques of limb lengthening. And yeah, you know what I started? I started with the Wagner technique, that old, the one that failed a lot and so on. That's what I was trained on in my residency. So I got a taste of the old methods. Then I got to go through all of the evolution of all these devices. I feel very privileged. I mean, what an incredible journey. Like I said, I was in the right place at the right time, had the right curiosity and hopefully the right skill set to get into this. And, you know, have become the most experienced limb lengthening surgeon probably in the history of Earth. Don't know if there's a spot on the Guinness Book of Records for that. But all that stuff aside, it's been fascinating. I mean, it's really been cool seeing this evolution, which is now 120 years old. And seeing it move so fast now, these devices, these new techniques, the things that we're able to do. I mean, we could never do this. Look, when I got into this, the most common way to treat limb length discrepancy was amputation. Cut off the limb, put on a prosthetic metal and plastic leg, because that you can lengthen as much as you want without pain, right? Just put on, get a new prosthesis. Well, we're past that, and we've developed so many new techniques. I'm not just talking about the limb lengthening. I mean, look, this wouldn't be possible with some of the other ancillary things that we've done, such as, developing procedures to reconstruct the hips, the knees, the ankles, of some of these terrible deficiencies like the super hip, super knee, super ankle, ulnarization, all procedures that I had the privilege to invent and develop. But it gives you a perspective of where we came from, what we've done, and now we have to say, so where are we going? And I'm jealous of the future generation. You know, I'm going to get to enjoy it for a certain period of time. But hey, look, my younger partners like Dr. Shen and Dr. Hughes are, you know, and many out there, they're going to get to do really, really cool things in the future that involve new biologic molecules and, you know, therapeutics and drugs that affect growth and all this. And they're going to play with new toys that I'm never going to get to play with, you know, eventually. So my perspective can be quite large, but many of these things we're not going to see. But I'll tell you what we're going to see in the next 2 to 3, even 5 years, which is exciting enough. So in the device field, we're going to see miniaturization. We're already seeing that. We're going to see devices for lengthening get smaller and smaller and smaller, to the point that they can lengthen a metacarpal bone, a foot bone, a finger, a toe, small enough that someone with a recessed jaw can have 2 of these devices put on and lengthen the jaw. They can move, you know, some kids born with all kinds of birth defects of the eyes, the orbit, and the mandible. They can move all those bones around. They can expand the cranium, or you know, for kids who are born with all kinds of defects in the skull. Those are just bones. So we're going to see miniaturization to the point that you can have externally remote control devices. Devices control with your iPhone. Okay, there'll be an app to lengthen your skull or lengthen your finger. And it's going to be done gently, and these devices are only going to be millimeters thick. Okay? This is not science fiction. I can tell you we're already working on such devices. We're going to see sensors built into these devices. Now, what are sensors? Well, right now, we're flying blind. We put in these devices, we build them strong enough, strong as an ox. We don't know what kind of forces they're resisting, but we're going to put sensors inside these devices that can measure how much load they're resisting. How much are the muscles pulling? How much how much force do you really need? You know, when you lengthen even a millimeter, the force goes way up and then it gradually settles down. If you do your next lengthening before the force settles down, you're damaging tissue. We know that. We have no way of measuring that. But imagine if on your little digital device, you do your lengthening of a 1/4 millimeter, and then you see the force go up, but it takes about 3 to 4 hours. You make sure it's gone all the way back down before you do your next lengthening. Having that ability is going to be incredible. In fact, we may eventually make a biofeedback loop, just like your thermostat in your room. You know, you set it to 70 degrees, it stays 70 degrees, right? It turns on and off the heat pump when you need it. Same thing here. We're going to set it that we never want to see the tension in the system get higher than this, and it will lengthen at that rate to make sure that the tension, you're going to have less problems with muscles, with joints, with nerves, with blood vessels, with skin, stretch marks, and so on. We're going to have sensors that tell you if the bone is healed. So that affects what activity you can do. Right now we look at an x-ray. What are we really doing when we look at an x-ray? We're looking at shadows. White, gray, and black shadows. How primitive. I mean, honestly, I do not want to be around when the future generation laughs at how primitive we were, okay? And say, they got these things called x-rays, and they looked at the shadows, and that's how they decided if a bone was healed or not. Oh my God. We're going to know it electronically. We're going to know it because we'll know how stiff the bone is, and when it reaches a certain stiffness, you can play sports. Okay? We're going to have all kinds of cool biofeedback sensor data. We're going to be able to correct deformities gradually. So if you have a crooked leg, instead of, cutting the bone and correcting it all at once, you could put one of these corrective nails or plates, and they'll slowly correct, but not in a straight direction, now in an angular direction. And they will make a bone straight from the inside. So this is coming. All of this is coming. We'll have drugs that allow you to heal the bone much faster. We'll have other drugs that allow the muscles and soft tissues to regenerate and grow. So the future is really exciting. And, it's been an amazing 35 years since I got involved in this technology. I'm not going anytime soon. I'm looking forward to a good number more of those years to be part of the development and part of the application of this latest technology. I can assure you that at the Paley Institute, we will always stay at the cutting edge. We will always be able to give patients the latest, the newest, the greatest options, and which then usually translates into the lowest risk and the lowest complications and the best functional outcomes. So it's been fun. It's been interesting. Past, the present, the future. This is a really exciting field. I feel privileged to have been at the center of it now for 35 years. I look forward to participating in it, for many more years. And I am really excited for all the various surgeons who are practicing in this field or will be practicing in this field. And I'm happiest for the patients, because the patients are the ultimate beneficiaries of all these technologies, all this, past, present, and future. Listen, thank you so much for tuning in, listening to me go on for almost an hour. And I'm available now to answer all the questions, and I am happy to stay as long as that takes. And I do have a list of some of them. So let me start with the ones that were sent to us before this presentation. Thank you for your patience and attending. I hope most of you are still there. Okay, so I'm going to take these questions in no particular order except the order they were submitted. Okay, one question was, there any future payment plans for young people who cannot afford to pay outright? Well, I think the person questioning is probably asking about cosmetic stature lengthening. And look, it's like any cosmetic surgery. The insurance companies do not cover that. There are some ways to get financing, just like anything you want to buy that you cannot afford yourself. And these are on our website. We have a special stature website, okay, which is www.limblengthening.org, O-R-G, okay. It is our stature, cosmetic stature website. Please log on to that, and some of that information is there. Question number 2, from what age the innovative limb lengthening operation can be done? What are the side effects? How many percent innovated way will be successful? Do you prefer the old way of lengthening, meaning using the external fixator? And how many centimeters lengthening per month in the innovated way? I assume the innovated way is referring to the implantable limb lengthening technologies. And I think what's good in this question is the question of, so what changes when you go from external fixation lengthening to internal implantable lengthening? Well, with internal implantable lengthening, the lengthening rate is still the same. So we always lengthen at whatever the safe rate is for each case. And the safe rate is based on how fast you can go and still regenerate new bone, and how fast you can go and still regenerate new muscle, nerve, skin, vessels, etc. In other words, soft tissues. The latter, the soft tissues, often govern the rate more than the bone. Bone usually can handle 1 millimeter a day of lengthening. The problem is the muscles, in particular, and the nerves can only handle a certain rate, and in different patients and different segments, it's a different amount. So in the lower leg, the tibia, we often lengthen slower, like 3/4 millimeter a day. In the upper thigh, we can lengthen 3/4 to 1 millimeter a day. But it's the same whether you use what he's calling the innovative method, which is the implantable limb lengthening. Implantable meaning the nails or the plates, or the external fixators, whether it's monolateral or circular. How many centimeters can we lengthen? So again, this varies. Anything under 5 centimeters of very safe lengthening. Complications start increasing between 5 and 8 centimeters. We do know when it's safe to lengthen more than 5, and this is an individual decision. It'd be too much to discuss to explain to you every situation where I might increase the rate, the amount from 5 to 6 to 7 to 8 and so on. But the 5 to 8 centimeters is the safe range. Beyond 8 centimeters in a single bone, you're starting to cause soft tissue damage, especially to the muscles. Okay. Now, if you want to lengthen more than 8 centimeters, you can lengthen in 2 bones at the same time, such as the thigh and leg bone, the femur and the tibia. So in dwarfism, as you saw, we're frequently lengthening both bones. And so we lengthen the femur and tibia simultaneously, frequently 8 centimeters each. Some conditions lend themselves to lengthening more and some less. For example, achondroplasia, hypochondroplasia, patients with dwarfism have very loose muscles. Their muscles are redundant. That means they have actually more soft tissue than bone, because the bone never wanted to grow, and the soft tissues did. And so when you lengthen in those patients, the muscles don't get so tight, neither does the nerve. And so you can get away with a much larger lengthening. If you compare that, for example, to fibular hemimelia or congenital femoral deficiency or radial club hand, there you're dealing with much tighter soft tissues, so you can lengthen less. You can get away with less lengthening per bone. And if you're lengthening femur and tibia, in those patients, you're going to lengthen less per segment than if you're lengthening any one of those alone. So there's a lot that goes into that decision, and this is really where the experience of the surgeon is really important. In other words, it's not just knowing how to put a device in or on the bone. It's about how to make these decisions, how to know what rate, what rhythm, how much to lengthen for each situation. And this is the advantage that very experienced centers and surgeons have over people who are not doing that much of this. What qualifies a child for the new limb lengthening procedure? So the answer to that is so external fixation, you can lengthen really down to the smallest bones. You can lengthen finger bones, you can lengthen toe bones, you can lengthen, metacarpals, metatarsals, forearms, almost any limb bone that there is, you can lengthen with external fixators. The implantable devices have a fixed length, okay, or minimum length, and they also have a certain thickness. And so you have to be able to accommodate that length and thickness either on the surface of the bone, or even more constrained is if you're trying to put it into the center of the bone. So our current devices are still not fully miniaturized. Okay, they're kind of designed for the majority of big bones, but they're not yet designed, for a 1 or 2 year old unless their bones happen to be unusually good size. Okay, and remember, a patient with a leg length difference already has a shorter bone than another patient of that age. Okay, because that's why they have a leg length difference. All right, so we are challenged by length, diameter. We're challenged by the presence of growth plates. So all of these go into the decision of, can I use an external versus an internal? The other part that goes into it is deformities. There's no question external devices can more easily correct deformities and can do it very safely and very accurately. Internal devices have more limitation in that respect. Okay, is it safe and is it recommended treatment for pseudoachondroplasia? We treat a lot of patients with pseudoachondroplasia. Pseudoachondroplasia, unlike patients with achondroplasia or hypochondroplasia, pseudoachondroplasia not only has the short stature and the disproportion, but they also have severe deformities of their bones and joints. And look, patients with achondroplasia, hypochondroplasia rarely get arthritis more than anyone else. But pseudoachondroplasia, the ultimate prognosis for most patients is to get arthritis, especially of the hips or the knees or the ankles. So in pseudoachondroplasia, the most important goal is to correct the alignment, correct the deformity, correct the stability of joints. So that's our first priority. Now, we've been very successful at combining that with lengthening. But in order to combine that with lengthening often requires external fixators. Can we do it with internal? The answer is yes, but not in every case. So I think it'll depend on particular cases. And what may be required is to first correct the deformities, get really straight limbs, and then put these implantable devices in, kind of do it in a two-stage fashion. We've used the implantable nails in pseudoachondroplasia, and actually quite a good number of them, after the deformities have been corrected. So it is possible. The other question was about the diameter of the bone. So that's not any more challenging in pseudoacons than acons or others. And like I said, in very young children, the diameter of the bone is too small, but you can use a device that fits on the outside of the bone, like a plate or an extramedullary rod. While in older children, there's enough room for the rods, even in pseudoachondroplasia. Is the internal device less painful than the external? And what about scarring? So the internal device is less painful than the external. You don't have these pins tethering the skin and the muscles. I think that's the main thing. And you don't get pin infections, which can be painful. So the internal is, I think, more comfortable to the patient. What about scars? So pins that go from the outside to the inside, they cause a reaction of the fat that's under the skin, and the fat gets absorbed. So and then the scar tissue develops along the pin all the way from the skin to the bone. When you take the pin out, you still have that tract of scar tissue, and where the fat was, you have an indentation or a dimple. So these are characteristic pin scars. You may have seen some on the slides. You don't get that with the internal devices. So you get, even though you have maybe bigger incisions with the internal devices, you don't get these uglier scars. And so the internal is, probably more cosmetic, more aesthetic than the external. For surgery to correct smaller amounts of limb length discrepancies, is it possible to shorten one leg as opposed to lengthening the other? If so, how much bone can safely be removed to achieve this in the tibia and fibula? So that's a great question. So first of all, whenever I speak to patients, especially children, I talk about there's two ways to correct leg length difference. Okay, one is to lengthen the short leg, but the other is to shorten the long leg. Now, in children, instead of actually removing a piece of bone, because they have growth plates, one of the things we can do is prematurely stop the growth of one or two growth plates. And we can do it in a very calculated fashion, so we know how much growth we're going to lose. So typically we don't want to do this for more than about 5 centimeters, 2 inches. And keep in mind, when we do that, you lose that in height. So you're losing it from the long leg, so you lose it in height. So we will do that in very large leg length differences where you want to reduce one lengthening, right? So if you had to do 20 centimeter lengthening total, that's 3-5 centimeters. And then what if you did one growth arrest? So that avoids having a fourth lengthening. Okay. We also do it, as an alternative in patients who don't mind the loss of the height. So in someone who, or someone in particular who's going to be tall, and you do a height prediction, and you say, well, your child's going to be 6'3", and so with this procedure they'll be 6'1", as opposed to undergoing a 5 centimeter limb lengthening. Growth closure is a much more minor procedure. It does have another downside. It's a little less predictable. So it's not less predictable, less accurate. So limb lengthening is extremely accurate. Growth closure is not as accurate. Now, what about in adults? Well, in adults, you can take out segments of bone, both femur and tibia. You're more limited in the tibia because there's 2 bones, less in the femur. I've done shortenings up to about 7 centimeters in the femur for leg length difference. So, and also for some people who are very tall, do ask us to make them shorter, and we've done that as well. So then you're doing it to both legs. Okay. By the way, there's even a technique, and a very old technique, where you take a segment of bone from one side and you put it into the other side. If you take 5 centimeters from one side and then lengthen the other side 5 centimeters and put that bone segment. The problem is that acutely lengthening 5 centimeters causes a lot of problems. So not a really good technique. It fell in disrepute, and very few people use that anymore. I was asked, how can you lengthen a short toe? So we don't often lengthen toes, but we lengthen the bone above the toe called metatarsal. Okay, and what that is, so a lot of people are born with what's called brachymetatarsia, which is shortening of the metatarsal bone. And so the toe looks short because it follows the metatarsal. And we use many external fixators to lengthen those. So our center does more lengthening for brachymetatarsia than probably any center in the United States. And we get them from all over the country, being treated here by a couple of us at the Institute. By the way, the same condition, brachymetacarpia, which is short, a little less common and certainly less bothersome, is shortening of one of these bones, is treated the same way. But currently, they're treated with external fixation. In the future, there's going to be little implantable lengthening devices that can do that. Okay. Do you think the modern age of technology that leg lengthening will become more common, less costly? Again, I think this is about cosmetic lengthening. And I think that, yes, it may become cheaper in the future. The problem is the devices, these implantable devices, are very expensive. I mean, for example, the stride nail is about $20,000 each device. So if you need it for both sides, that's $40,000 before hospital costs, surgeon's fees, or anything, physical therapy, or anything else. So the floor is the cost of the implants. Now, right now there's one company producing these. Sure, if there's competition and there's a lot more devices, prices may drop. If there's a lot more people doing the surgery, prices may drop. So stay tuned. That's all I can tell you. So those were the ones that were sent to us prior. We have a bunch of questions that have been posted since I began this talk. So Caroline is going to read these out to me.
When can we expect sensors to be installed inside the lengthening device?
So I can tell you right now, there's a couple companies working on this with devices that could see the light of day maybe in 2022 at the earliest.
Will the kids be able to keep the plates in, lengthen, and several years later restart it and lengthen more?
Yeah, so these devices are, right now, they're approved by the company for one-time use. Remember, when they've lengthened, they're in the maximum lengthened position. If you wanted to reuse it, theoretically, you'd have to take out the screws at one end, and this is the same for the rod or the plate. You'd have to reverse it all the way, reattach that one end to the bone, and then re-break the bone and start again. This has been done with a nail. It hasn't been done with the plate yet. Company is not keen on that. They'll tell you because they're worried about the implant breaking. Obviously, they're not going to make a sale if this is done the second time. But there is a consideration of the device. You know, there's no experience to say how long these devices are good for, and if they would break, or the mechanism would break, or the device would break during that second lengthening. So in theory, what is mentioned has been considered, may have even been done. In practice, in the United States, that's not within the standard of care.
When do you expect arm lengthening to be internal for pseudoachondroplasia?
So the question was, when do I expect arm lengthening to be internal for pseudoachondroplasia, or you could say achondroplasia for either. We already are doing arm lengthening internally. So first of all, arm lengthening right now with the implantable, we're using the nail, the internal device. the shortest nail will fit into the arm of a skeletally mature patient with achondroplasia or pseudoachondroplasia, but it will only lengthen 5 centimeters. Most patients with dwarfism who undergo the extensive limb lengthening that we talked about of 30 to 40 centimeters, 12 to 16 inches, in order to lengthen the arms proportionately, they need about 10, at the most 12 centimeters of lengthening. There's no device that will do that much. The external fixator can. So then you have to do the arm lengthening twice. If you're willing to do it twice, then, and we have done that. We have several patients that we've done 2 5-centimeter lengthenings. Then it can currently be done. The plate has never been used on the arm, but I'm sure it will be. You just have to, with the plate, you just have to be careful to avoid injury to the radial nerve, which runs along the bone, which with a nail you don't have to worry about that. So there's some technical issues, but arm lengthening is currently being done in patients with dwarfism, as long as you're willing to accept doing it twice if you want to get 10 centimeters.
Is there any hope for older patients? At 45, I feel it's too late for any of this, but this is just incredible.
So the question is there any hope for older patients? The person writing is 45. That sounds really good age from where I'm standing. Please don't call yourself older at 45. It makes me feel really old. All kidding aside, we lengthen patients well into the 60s for different reasons, especially for leg length difference. I've had numerous patients that I've lengthened, one limb to make them equal, even in their 60s. I think my oldest patient that I did that on was in their early 70s. For stature, and this is pure for cosmetic stature lengthening, we've had patients, the oldest is 65, who are very healthy 65, and we very successfully lengthened. And by the way, that individual healed faster than some of my 16-year-olds healed. So people have the ability for bone and soft tissue regeneration and healing really throughout their lives.
My baby was born with a 2-centimeter difference between both femurs. He is currently 2 months old. Is it only corrected with surgery? At what age is correction recommended?
So the question was about a congenitally short femur in a 2-month-old with 2-centimeter difference. It's 3/4 of an inch, and asking what age is correction done, and can it only be done by surgery? So first of all, limb length discrepancy cannot be corrected by any drugs or mechanical means or and so on. So the only way to treat limb length discrepancy, other than the use of a shoe lift, is with surgery. So if you want to equalize the limbs, it requires lengthening or slowing growth, one or the others. So either shorten the long leg or lengthen the short leg. Now, in a patient just born with congenital femoral deficiency, kind of a rule of thumb, if it's a boy, whatever the discrepancy at birth, it's going to be 5 times that at skeletal maturity, and if it's the girl, it's going to be a little over 4 times. So if it's 2 centimeters, you're looking, if it's a boy, 10 centimeters at maturity, if it's a girl, about 8 centimeters. And, we look to see whether they have hip or knee or ankle problems, and usually we fix those first, and then we do the lengthening surgery second. And really the age for the lengthening, in a kid like this, let's say has a predicted discrepancy of 10 centimeters at skeletal maturity, I would do one lengthening under the age of 4 and one lengthening closer to skeletal maturity, or the second one could be a growth closure instead of a lengthening. Good rule of thumb for everybody to remember is that boys reach half of their limb length, and therefore their limb length difference, by the age of 4. Girls reach half of their limb length, and therefore their limb length difference, by the age of 3.
Are you planning to perform this innovative surgery also in Poland? There are many children who would be interested in this in Europe during COVID times. What are your plans?
So we, those of you who don't know, we have opened a European branch of the Paley Institute called the Paley European Institute, PEI, in Warsaw. And we have a whole staff there. We have 2 surgeons that we work with there. We have our own offices and a hospital that we work at called Medicover in Warsaw. And we go there, Dr. Feldman and I each go there about every other month. So once a month, one of us is there. I just got back from there a little over a week ago, and I'll be back there in December. We are performing, Europe has a different FDA than we do. It's called CE mark. And so the precise plate is not yet CE marked for Europe, but the precise nail and the stride nail are. So we already are performing these stride nail and the precise nail in Europe at Paley European Institute. In fact, when I was there, I guess 10 days ago or so, we put in 2 or 3 of these precise nails on patients from all over Europe. A couple of kids from Russia, from Poland, from other countries that came there, and we did those techniques there. The precise plate is not available in Europe. Even in the United States, it's currently only available in the hands of about 4 surgeons, and so it's too early for that to be available in Europe.
All right, we're about out of time. So we've...
All right, I think that kind of wraps it up. I thank you all for your attention, and you know, if you guys have additional questions, post them on our site. If you include your email, I will personally answer them. So feel free to post your questions, and we will try and get you an answer to you know, all your queries. And have a wonderful weekend, everyone. Thank you for tuning in, and everyone stay safe. Thank you.